This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
And welcome to the human side of healthcare. We're delighted you're with us today, and we want to talk about a subject related to pediatrics and especially your heart, just in normal circumstances, then with the outbreak of COVID, and then even side effects from the vaccine. We couldn't have a better person to talk to than Dr. Ryan Butts. He's a pediatric cardiologist at Children's Health and also an associate professor at UT Southwestern. Dr. Butts, welcome to the show.
Thank you for having me.
Why don't we explain to our listeners first, what is myocarditis and what is pericarditis?
Sure. So myocarditis is literally just inflammation of the heart muscle. Pericarditis is inflammation of the lining around the heart. So myocarditis and pericarditis, and sometimes the conditions can go together, called myopericarditis. Myocarditis, which is a little bit more common than pericarditis, happens in children typically around in the first year of life, or more often in teenagers, but can technically happen anytime during their lifespan, and is usually associated with a viral infection of the heart muscle, and then you get inflammation that occurs because of that viral infection. There are sometimes some other causes, such as in teenagers, teenage females, you can sometimes get myocarditis associated with lupus. And some other different infectious diseases can cause myocarditis. But by far the most common cause in the U.S. is actually a virus. And often they're respiratory viruses, so they're the common things that you think of, such as adenovirus, the flu, Epstein-Barr virus, cytomegalovirus. So these are common viruses that a lot of people occur, and then just at the wrong time and the wrong person, unfortunately, can go and infect the heart. Albeit it's still incredibly rare, and less than 1% of children will experience myocarditis in their lifetime.
And then what is pericarditis, and what causes it?
Pericarditis is often due to a viral infection, but also we can see occur after heart surgery, when that lining of the sac is opened in order to do heart surgery, and then gets inflamed afterwards. And it's sometimes seen in children who have problems with their kidneys and get too buildup of metabolites that their kidneys are unable to get rid of, and then that causes the inflammation. And then also seen in lupus and some other rheumatological disorders. But overall, most patients who get myocarditis and or pericarditis do incredibly well. They may be sick for a short period of time, but over close to about 90% will go home after being admitted to the hospital with myocarditis without any advanced treatment needed. And in pericarditis, that's nearly 100% will go home doing well.
So in other words, for the most of the people, once you treat that episode of care and you discharge them, generally, there are not longer-term treatments required.
That's definitely true for pericarditis. That usually doesn't need long-term care unless it's associated with something else, such as, like I mentioned, that they had lupus. They may need treatment for their lupus. They may need treatment for their kidney problems, but not necessarily for their heart specifically. In myocarditis, what happens a decent amount of time, probably about 50% of the cases, they may need to go home on some oral medications to continue to let their heart recover. But usually those are weaned off over maybe 6 months to a couple of years, depending on each individual patient. But the long-term prognosis is incredibly good.
You know, the Delta variant has really hit the pediatric population pretty hard. How has this virus really impacted pediatrics today in this latest wave?
Particular myocarditis and pericarditis, they have been seen in COVID-19, especially when patients get what you may have heard called MIS-C, or multi-inflammatory syndrome associated with COVID. And in those patients, we do see a myocarditis and pericarditis pretty frequently. And luckily, similar to other myocarditis, usually as the COVID infection gets better, the myocarditis and pericarditis go away.
Many of the children 12 years of age and older have received Pfizer. How many would you say have had a reaction to the vaccine?
No, that's a great question. So in June of this year, before the Delta wave, the CDC actually tracks the adverse events from any vaccine very closely through a vaccine adverse event reporting system, or VAERS. And when they looked at the frequency of seeing myocarditis after the second dose of the vaccine, they were able to get an estimate that if 1 million boys between the age of 12 and 19 received the COVID vaccine, that approximately 40 would get myocarditis. And then the same in females. If 1 million females were given between the ages of 12 and 19 were given the second dose of COVID vaccine, that approximately about 10 or so would have myocarditis. That being said, at the same 1 million people who were, if they weren't given the COVID vaccine, about 11,000 would get COVID, and over about 100 to 200 of those males would be admitted to the ICU, and about 100 to 200 of those females would be admitted to the ICU. And the second part to know is that the myocarditis that's been associated with the vaccine has been over and over again just very mild cases, where kids may complain of chest pain, may have some abnormalities of their lab test. In order to confirm the diagnosis, often an MRI is performed. They will get admitted to the hospital for observation, but everybody has had very mild cases that's had full resolution, and they've gone on with their lives afterwards with no significant sequelae. This is all to say is that basically any chance of having any side effect of myocarditis from the vaccine is significantly outweighed by the sequelae and the disease burden caused by COVID.
So when you look at the risk-benefit, in your opinion, the benefit is much greater than the risk when it comes to children getting the vaccine. Is that correct?
Yes, I think over and over again, all the scientific evidence points at the risk of getting COVID, especially in that numbers I quoted you earlier in June, are really before the Delta wave. And this Delta wave has definitely affected children more than the previous waves. So if we put that all together, the risk benefits even before Delta were in favor of getting the vaccine, and especially with the Delta variant, they're significantly in favor of getting the vaccine. I think where we get hung up a little bit is that all this is new. COVID is new. This vaccine is new, and new things get us a little bit concerned and often bring on the emotional side of us. And we all make risk-benefit choices every single day. I mean, I make a risk-benefit choice to drive I-35 in to work today. Anybody who's driven I-35 knows that there's plenty of risk associated with that. But every day I figure that the risk is worth the benefit of getting to work and getting paid. But when it's something new and you're not used to, it can cause a lot more fear than is necessary. And really and truly, the science truly bears out that these vaccines are very safe and effective.
We're listening to Dr. Ryan Butts. He's a pediatric cardiologist at Children's Health and also an associate professor at UT Southwestern. If you didn't catch all of this, it's on our podcast, The Human Side of Healthcare, on all the major podcast players. When we come back, Steve and Dr. Butts continue this conversation. Stay with us.
This is The Human Side of Healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back to The Human Side of Healthcare. We're continuing our conversation with Dr. Ryan Butts, who is a pediatric cardiologist at Children's Health and also from UT Southwestern Medical Center. We're exploring these two issues that we've seen in the news lately related to our hearts, especially our young people, myocarditis and pericarditis. But first, there was some news this week that we need to ask Dr. Butts about. Steve?
You know, Dr. Butts, this week the FDA recommended that we have the vaccine for children 5 years of age up to 11 years of age. Now, the CDC is going to look at this in early November. Do you think they will agree with the FDA and approve it also?
I sure hope so. I think at least the preliminary data they've released so far it seems that they could be favorable outcomes from the trials, and that eventually we will be vaccinating children 5 to 11. And I think it'll history tells us that children do very well with vaccines. They've done that over and over again, and many children get vaccines throughout their even much younger than age 5 and do incredibly well and develop the immune response that they need to protect them for significant infectious diseases.
What are some of the signs and symptoms parents need to look for that their child may be beginning to have difficulty with this?
Absolutely. So it depends on the age of the child. A adolescent, teenager, is going to usually present with more likely chest pain, a little bit of shortness of breath, and often there's a degree of fatigue. Your school-age child, sort of your elementary age school child, is going to be complaining less of chest pain, more likely of just fatigue, significant amount of malaise, and often difficulty with breathing, as well as often vomiting or other loss of appetite. An infant is most likely to develop respiratory distress, so breathing fast and working harder to breathe, and often lack of appetite and a significant amount of vomiting without diarrhea.
So these diseases we've talked about, because you're a pediatrician in children, can they also impact adults?
Yes, myocarditis and pericarditis are both present in adults as well. And similar, they have different patterns of presentation based on age and causes in adults.
So when we look at some of the side effects of the vaccine, would you say people under age 30 have been impacted more with these side effects than, say, the more elderly population?
Overall, it does seem that people with a more robust immune system are more likely to have some adverse events, as we may say, but they're usually very mild, such as developing a headache, muscle fatigue, soreness, fever, backaches, and those things are short and usually less than 24 hours worth of symptoms. And still, again, in comparison to developing COVID and being incredibly sick in the ICU, these side effects are very mild compared to the disease.
You know, you've done a great job answering my questions, but for our listeners out there, especially the parents, is there any takeaway message that you would like to leave with them related not only to the subjects we've discussed, but COVID-19 and its impact on pediatrics?
Yes, the take-home message I would give is if your child has access and is old enough to get the vaccine, go ahead and get them vaccinated. That by far is the safest thing that you can do for your child and to protect their health for the long term. And as this vaccine becomes available for younger age children, once the FDA approves it, please, I would very much consider and encourage everybody to go get their child vaccinated so we can help stop this pandemic.
Dr. Butts, you've done a great job answering my questions, but I can tell you Thomas always has excellent questions. So, Thomas, I was going to see what questions you might have.
Thank you, Steve. Dr. Butts, I'd like to take a tact on this of one area of our life that does not need a study, because I think there's about 100% chance or certainty of this, is that parents talk. They talk to each other and they talk about their kids. Would you agree?
Absolutely.
Yeah.
Who wouldn't? I talk about my kids all the time.
How old are your kids?
My kids are 14 and 16.
Oh, okay. So they're right in this age group then that's part of this conversation. So one thing
Absolutely.
So this is perfect. So you're right there as a parent. So I didn't realize that these two illnesses, pericarditis and myocarditis, are offshoots of a respiratory infection. Could you drill down on that just a little bit more? That really crystallized a different angle on this.
Sure. So myocarditis and pericarditis, and more specifically the myocarditis, which is what we actually see more often in pediatrics. Respiratory viruses, even though they come in through the lungs or in your nose, and then even your gastrointestinal viruses, so the things that you think that cause the stomach bugs, they get in. At one point, you have what we call viremia, which is just a fancy medical term for the fact that the virus is in your blood. And when the wrong strain of the virus meets with the wrong person at the wrong time, sometimes that when the viruses in the blood, it can attach to the heart muscle, and that's what causes myocarditis. And so these are usually common viruses that all of us have been exposed to at some point in our life, and many times exposed to more than just once, and then end up causing myocarditis. So this is a little bit like, unfortunately, winning the wrong lottery. It's the wrong place, the wrong time, with the wrong virus and the wrong person. It's nothing that anybody can really do to avoid.
Do your kids play sports?
My oldest does color guard.
Okay. So, we hear stories in North Texas, it seems like almost every year. And it's always usually around the preseason, but an athlete will die suddenly on the football field or the sports field. And typically it seems that it comes back to something related to their heart. What's happening there? What's the breakdown that causes them to have a sudden death?
So the most common reason for a teenage athlete to die in the middle of exercise is something called hypertrophic cardiomyopathy, not myocarditis, but hypertrophic cardiomyopathy. And hypertrophic cardiomyopathy is a condition in which the muscle of the heart is overly thick and then can cause decreased blood flow to the heart muscle and then set the child up for an abnormal heart rhythm while exercising. These cases are incredibly rare. It's less than 1% of children, but obviously they're incredibly frightening and often end up in the news just due to the motion of having what seems to be a very healthy child out there in the middle of sports competition dying. The condition of hypertrophic cardiomyopathy can often be detected at first by hearing a murmur, in which the pediatrician often will ask for a cardiologist evaluation afterwards.
So completely unrelated to anything that we're talking about here with either getting COVID or having a reaction to the vaccine. No relation whatsoever.
Not when exercising. We do ask the patients who have myocarditis, after they've had myocarditis and their heart muscle is still recovering, to stay out of competitive sports for about 6 months, just to let their heart muscle continue to recover. But in terms of the vast majority of the cases that you've seen on the news, they are not related to myocarditis. They're either hypertrophic cardiomyopathy. The other thing I haven't talked about is occasionally there's from a coronary artery that comes off of the wrong area. This often has some preceding chest pain with exercise, in which they should be evaluated by a cardiologist if the patient experienced that.
Obviously, with any kind of reaction to the heart. Which vaccination or vaccinations, plural, are we talking about that are leading to these possible reactions?
It seems to be more common in the Pfizer and Moderna, not as much with the Johnson & Johnson.
Is that then maybe if a parent is thinking about getting their child vaccinated, should they look at the J&J? Or it seems to me, just from my perspective, that we don't hear a lot about the J&J related to younger people.
We don't. It hasn't been studied as much in the younger children and doesn't have FDA approval. So that's why you hear more about the Pfizer and Moderna, because that's the one that's been studied. And the Pfizer is the one that's being studied with the 5 to 11-year-olds currently. So again, going back to the risk benefits of anything that we do, the Pfizer and Moderna and the vaccines were 95% effective in preventing severe COVID illness. And the Johnson & Johnson was good, but it wasn't as effective. So since the chance of getting myocarditis as an adverse event from the Pfizer or the Moderna COVID vaccine is so low, but those vaccines are so effective, I would still say it very much favors going to getting the Moderna and Pfizer versus getting the Johnson & Johnson. Especially now, when all the vaccines first came out, it was we were at a shortage, and now that we're have a nice surplus, I would still very much to my patients suggest that they get the Moderna or the Pfizer.
What an awesome side of medicine, pediatric cardiology. Taking care of kids' hearts when they need it the most. Dr. Ryan Butts from Children's Health and UT Southwestern Medical Center, thank you so much for joining us. When we come back, we're going over to Methodist Richardson Medical Center. Dr. Jenevieve Hughes is a surgeon specializing in breast disease, and we're going to talk about breast cancer and genetic testing next on the Human Side of Healthcare.
Welcome back to the Human Side of Healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome to the Human Side of Healthcare. We're delighted you're with us today. And today we're going to talk about cancer screenings, the importance of those screenings, and even talk a little bit about breast disease and breast surgery. We're delighted that we've got Dr. Jenevieve Hughes with us today. She's a board-certified general surgeon. She specializes in breast disease, breast surgery, and practices at Methodist Richardson Medical Center. Dr. Hughes, welcome to the show.
Thank you so much for having me.
You know, I know we've talked about this previously, but I am going to ask you something. Now that we're about 19 months into this pandemic, are people pretty good about coming in for routine diagnostic procedures, or do you still see people putting their screenings off?
That's a great question. And unfortunately, we still see people putting their screenings off. Some people have been able to get caught up. We saw more delays initially on in the pandemic, but unfortunately, we are still seeing people who have had their screenings delayed and trying to get them caught up.
You know, as far as some of the screenings that you recommend that people cannot put off, can you rattle off a few, especially for women, that they just should never put off?
Sure. I think for women of most ages, an annual exam with their doctor, their primary doctor, and or their gynecologist is really important and is a great jumping off point, a great starting point for determining what additional screenings are needed based on that person's age and their personal history as well as their family histories. Certainly for cancer screenings, as we get a little bit older, those become more important. We typically recommend screening mammograms in women over the age of 40, sometimes earlier if they have a family history. And then other cancer screenings are important as well, colon and rectal cancer screenings for both women and men, prostate cancer screening for men, lung cancer screening for people that have a smoking history would be some examples.
You know, when you do a mammogram and then you subsequently do a biopsy and it comes back positive, how do you as a physician talk to the patient and calm their fears?
Well, we try to take a team approach, first of all. The way I view every new patient that I see in my clinic is as the center of a team that is going to be built. And it's really important that that woman is comfortable with her team. And we talk about who needs to go on that team at the first visit. And we typically will try to build a team of experts around her, of different specialists in the different areas of treatment for breast cancer in particular. So we talk about a team approach and we talk through the results. And that helps tremendously in terms of then being able to formulate a plan. And that plan, having a plan in hand, is typically somewhat comforting to know, okay, here's what I'm dealing with, here's what has been found, and here's what we need to do about it.
When a biopsy comes back positive, is it possible genetic mutation may have impacted that?
Yes, absolutely. For multiple different types of cancer, genetics and family history are very important. For breast cancer specifically, for any woman of any age who gets diagnosed with a breast cancer, we need to perform an assessment of her family history to look at other cancers that are in the family. And one common misconception is that only the mother's family history matters, and that's not true. Both the mother's and the father's family history, both the maternal and the paternal histories, are very important. And so one of the things that I do at the first visit, once we know there's a cancer, is we do what's called a pedigree, where we literally draw out and diagram out that person's family tree so that I know who is in the family, how many brothers and sisters, how many children, how many aunts and uncles, etc. And then we talk about each one of those people and their histories related to cancer. And we try to capture any cancers that are on either side of the family. Once we've done that, then we can make an assessment about what is the level of concern for a genetic breast cancer. And genetic breast cancers account for about 10% of all breast cancers. Sometimes that surprises women. They think that it's a much higher chance that a cancer is genetic, but actually most breast cancers are not genetic. But in about 10% of women, if we do genetic testing, we will identify some type of gene mutation that could be increasing that person's risk for getting cancer. So we do that full assessment at the time that the cancer is identified to then determine whether we need to consider any genetic testing for that patient.
Should people that have a family history of cancer get more frequent screenings than annually?
So it depends is the short answer there. One of my areas of interest is in breast cancer risk, and we run a program here called the High Risk Breast Clinic, where I will see both women and men who may be at increased risk for breast cancer to help determine what to do about that risk and how much risk they have. And in that high-risk clinic, we start off with an assessment of that woman or man's medical history as well as their family history, and then we calculate out what their breast cancer risk is, and we can actually use several different types of risk calculators to get an estimate of what that person's risk of getting breast cancer is and what that person's risk of having something like a genetic mutation is. And then once we know those results, when we know those risk estimates, that allows us to then determine what we can do about them. And like you said, we have options there. We can potentially screen more closely. We can do more than just the typical screening mammogram that would be recommended for most women on an annual basis. Sometimes we add in additional tests like ultrasound or breast MRI. Sometimes we need to consider doing genetic testing even for someone who has not had a breast cancer because they have such a strong family history. Maybe there are other family members that have had cancer that are not able to be tested or are not still living. And so we will test women sometimes that have not had a breast cancer to look for a genetic mutation, where then that can help us to determine how we manage their risk. Sometimes we use risk-reducing medicines to help prevent breast cancer. We talk about lifestyle risk factors, things like smoking or alcohol use or obesity or lack of exercise as all being important risk factors that women can work on to reduce their risk. And sometimes for our highest risk patients, we will consider doing risk-reducing surgery. That usually involves removal of both breasts, a mastectomy on both sides to reduce the risk for our highest risk women.
You know, many women obviously are very concerned, about a mastectomy. In certain forms of breast cancer and breast treatment, are there things you can do short of a mastectomy?
Absolutely. In 2021, women have lots of options. Some of those options are determined by the cancer that they have, as well as the woman's preferences. But for many women, they do have options to conserve their breast if the cancer is earlier in stage. And we talk through those options, and we talk about the pros and cons between lumpectomy and mastectomy. And the good news there is that for many women, the overall results, like the survival rates, are the same whether they have a lumpectomy type of surgery or a mastectomy type of surgery, as long as we can get all the cancer out with whatever surgery that we are doing. And so many women have an option. At our center, we do about 65 to 70% of our surgeries are breast conserving surgeries, not mastectomy surgeries. Women that do have a mastectomy have options in terms of reconstruction, and that reconstruction usually can be started at the same time as the mastectomy surgery. And so there's options there as well.
As a physician, what is your main message to women concerning breast cancer?
A couple of things. I think the first is the importance of self-care. Sometimes, especially as women, we tend to be caregivers for other people in our family, our children, loved ones, and sometimes we neglect our own self-care. And your own health starts with your own self-care and the importance of eating healthy, exercising regularly, getting enough sleep, getting enough exercise, making sure that you reduce your stress. Those are all really important things that we can do on a day-to-day basis, even during a pandemic, to make sure that we're taking care of ourselves. And then, like you mentioned earlier, make sure we're following up on our own health care, that we're getting the appropriate screenings. Have a conversation with your doctor about what is recommended for you based on your age and your medical history and your family history. I think that's really important. In terms of breast cancer, a lot of women don't know what their risk is, and they don't even know that that risk can be calculated. They don't know their family histories and how that impacts their risk. So I think knowing and arming yourself with that information is really important. And then for women to be aware that the vast majority of cases of breast cancer are treatable, and our goal with those cases is to cure that cancer and do what we need to do to prevent it from coming back, and that the treatments have gotten easier through the years, and that there's support there. Like I mentioned earlier, there's a team there to support each and every one of our patients, and that we can get them through the treatments that are needed. And the outlook is so much more positive now than it was years ago.
We're listening to Dr. Jenevieve Hughes. She's a surgeon at Methodist Richardson Medical Center who specializes in breast surgery. And we're going to continue this fascinating, cutting-edge technological conversation about how we can help prevent and treat breast cancer better. That's next. Stay with us.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're continuing this fascinating conversation with Dr. Jenevieve Hughes. She's a surgeon specializing in breast disease at Methodist Richardson Medical Center. Talking also about genetic testing, something that has become a valuable tool in the hands of folks like Dr. Hughes. And I'd like to start with a question about if somebody gets cancer and then gets a gene test, how valuable is that test?
Oh, I really appreciate that question. I think that's an important one. And it's important for women to understand not only what test is being recommended, and there are different tests out there on the market, but also then what are the implications of the results of that test. And it's valuable whether it's done before someone has cancer or after they have cancer as well, but for slightly different reasons. For someone before they have cancer, it can be valuable in terms of helping to prevent a cancer. For someone after they have cancer, it can be valuable in terms of guiding their treatment for that cancer and also potentially helping them to prevent other types of cancer. When we look at these cancer genes, and I'll just throw out there that the BRCA or BRCA genes, there's two of them, BRCA1 and BRCA2, are the most common genes to be associated with breast cancer, but they are certainly not the only genes. There are multiple other genes that can be associated with breast cancer. And all of those genes are not just associated with breast cancer. They can also be associated with other types of cancer, and each gene is different in terms of what the risks of each of those cancers are. For example, the BRCA genes can also be associated with ovarian cancer in women, with prostate cancer in men, with pancreatic cancer. So there can be other cancers that someone might find out that they are at risk for if they are found to have a genetic mutation. So to go back to your question, and somebody who has already been diagnosed with a breast cancer, that genetic testing can be helpful in finding out not only was their cancer caused by a gene mutation, but also are they at increased risk for getting another breast cancer in the future. Some women, especially women who have BRCA or BRCA gene mutations, are at very high risk for getting a second breast cancer. And sometimes that changes what they decide to do in terms of their breast cancer treatment. Some women will consider preventative double or bilateral mastectomies, not to treat the cancer that they have necessarily, but to prevent a new one from occurring in the future. And then it also may impact what they do in terms of screenings and prevention for those other types of cancer that are associated with whatever genetic mutation is found. And then we have to consider not just the implications of gene testing on the patient, but also on the patient's family. Because if we find a genetic mutation in someone, then any children that they may have a 50% chance of inheriting that gene mutation. Any siblings of that person, brothers and sisters, have a 50% chance of inheriting that mutation. And sometimes there are other relatives, whether it be aunts and uncles or cousins, that may also be at risk and may need to consider testing for themselves. So genetic testing has implications not just on the patient, but also on that patient's family.
Is it a standard of care now?
That's a great question. This is an evolving field. Genetics has changed tremendously over the last 15 to 20 years. What we were able to test for back in the early 2000s is quite different now than what we can test for in 2021. Typically in 2021, we do panel gene tests where we test for multiple cancer genes all at the same time. And what used to take months and months of testing back in the early 2000s now can be, we can get a result within 2 to 3 weeks, sometimes even a little faster than that. So the genetic testing field and genetics for cancer has evolved tremendously, and so have our indications for doing those tests. And nowadays, like I mentioned earlier, we consider genetics and genetic testing for every patient that gets diagnosed with breast cancer. Not every patient usually is tested. There are different sets of guidelines that we use. For example, the American Society of Breast Surgeons has fairly recently recommended that genetic testing be at least considered, if not done, on every woman with breast cancer. The National Comprehensive Cancer Network, or NCCN guidelines, they publish guidelines basically involving all types of treatment for breast cancer, and the guidelines for genetics for NCCN are a little bit different, and we are looking for certain patterns in the family, certain family history, as well as looking at the age that a woman gets diagnosed with breast cancer, because we know that women who get diagnosed at younger ages are more likely to have a genetic syndrome. So we look at the age and the type of breast cancer as well to help determine who qualifies for genetic testing using those guidelines. And right now in 2021, those NCCN guidelines are the ones that most insurance companies use to determine if they're going to pay for that genetic testing, and that's important that we factor that in as well. Okay,
great. So if you get a genetic test, can it help determine the spreadability and where it might spread?
Not really. What it can help to determine is where it might start. And that's where we find out sometimes there's a risk of getting breast cancer, or a risk of getting pancreas cancer, or a risk of getting ovarian or uterine or colon cancers. We can learn on those tests. But the tests, first of all, do not tell us that that person will get a cancer. It just gives us an estimate of what their risk might be, and those tests can tell us that their risk might be higher than the average person. But it's different for every gene.
Can operating on a tumor cause it to spread?
That's a common question that I get, and we don't have any evidence of that for breast biopsies. The benefits of knowing the results from that biopsy and then allowing us to move forward with treatment by far outweigh any even theoretical risk there that could happen.
Obviously, a patient and their physician have to discuss treatment options, and that's a big, broad area depending on what you're dealing with and has so many factors, right?
It sure does, yes.
If the oncologist recommends trying to reduce the tumor before surgery, is there an offsetting risk of that tumor actually spreading before it is taken out of the body?
Okay, I think I understand your question, and you're absolutely right. These are big discussions that happen from a whole team, whether you have a surgeon weighing in, you have a medical oncologist weighing in, a radiation oncologist weighing in on treatment recommendations. We all work together very closely to try to come up with the best treatment plan for that individual patient. And sometimes what that means is that surgery is not the best first treatment for that patient, that it would be better to, just like you said, try to shrink a cancer before we try to remove it surgically. And there's different ways to do that. The most common ways to do that would be with chemotherapy or with endocrine therapy, which is also known as estrogen or hormone blocking medicines for breast cancer. And sometimes we can use either one of those types of treatments to shrink a cancer and make it easier to remove with a surgery. And so those are team decisions in terms of deciding whether that would be appropriate for any person's particular situation. And yes, that's one of the risks when we do what's called neoadjuvant therapy, which would be doing chemotherapy or estrogen blocking medicine before surgery. The term for that is neoadjuvant therapy. And there are risks associated with that. And one of the most common risks or questions that I get asked about that risk is, what about the cancer? Could it grow during that time? And the good news there is that when we select our patients carefully, meaning we do that type of treatment when it's indicated, that the vast majority of the time the cancer does not grow. It shrinks. And sometimes it shrinks completely away. When we do surgery, we don't find any residual cancer there at all. We call that a complete response. So we try to assess that. We certainly don't want to do neoadjuvant therapy on someone where we think there's a high risk of the cancer growing during that time.
Dr. Jenevieve Hughes, surgeon from Methodist Richardson Medical Center. I love these technological stories, and gene therapy and what she was talking about, the latest techniques in breast surgery, are at the forefront. Steve?
Great points, Thomas, as you said. And to our listeners, thanks for joining us today. Have a safe and happy Halloween, and join us next Sunday for the human side of healthcare.